Okay, this is the second part of the first chapter. Now we finished with the DEA we talked about. Now we're going to talk about pharmacodynamics, and this is the drug effects on the body itself. This is how the drug works on the body and how it changes the cells' activity. It either will increase or decrease or stop certain cell activities. So that's when we're talking about the pharmacodynamics. Now, the mechanism of action, that is how the drug changes the activity of a cell. Every drug will have an action, and we talked about that already. So it's the mechanism of action. Now, target tissues, that's the area of the body where the drug is going to actually affect. For example, pain meds will actually work on the cells of the brains so that you perceive that you're not having any pain. So it will work on the cells of the brain for pain perception. And then we're talking about receptors. Now remember, we're talking about biology stuff here. So just remember, you've had biology. This is just freshening you up about the biological stuff. You won't be tested over the biology. It's going to be all about the pharmacy stuff. All right, so we're going to talk about receptors. Now, receptors is always talking about locks and keys. I always think of locks and keys when it comes to the receptors. It's the part of the cell that the drug attaches itself and will control certain activities of the cell. Okay, so cells have these little locks and keys. Okay, there's a lock, and keys will come in and try and fit into those locks. But each receptor cell, they have these locks, okay? The key goes into the lock and it will cause certain functions. So if a key goes into a lock, it either can increase a function, it can cause, decrease in a function, it can actually stop a function. The keys are going to either be intrinsic or extrinsic. So keys can be something that we internally made in our body that will lock onto that, or it can be extrinsic. Maybe we took a pill and that key came from that pill and it goes onto those receptors and causes the action to either increase, stop, or decrease. We have different receptors on cells that will accept only certain drugs. Okay, the drugs will only affect cells if it fits into that lock. Otherwise, it won't do anything to that cell. They are found on the cell or inside the cell, and drugs can affect one or more cells. Okay, so sometimes it will affect different cells, that medication. Now, when we're talking about the receptors, we're talking about different. We have receptor agonist and we have receptor antagonist. Now, receptor agonist, those are extrinsic drugs which attach to a cell receptor, and it causes the same response or action that the intrinsic drug does. Perhaps, think about it. If you don't make a certain amount of hormone or something, sometimes we have to give you medication to help with that. So that would be a agonist. It is actually doing the job that an intrinsic drug would do. It's helping. Extrinsic drug is the receptor agonist. That would be called the receptor agonist. The stronger the bond, the stronger or the longer the drug will stay on the cell, and the stronger the effects of the cell. All right, so remember, receptor agonists, those are the ones that are kind of helping, and they're going to attach on and do the same thing as an intrinsic drug would do. Now, receptor antagonists, those are the ones that are naughty. They antagonize. Think about little kids. They antagonize each other, nanny, nanny, poo, poo, things like that. So this is the same thing with that antagonist. Extrinsic drug that will stop or slow down the action of the drug. So it's actually going to stop it. It's going to get in there and hit on that lock and stop it. They prevent intrinsic drugs locking into the cell. So perhaps you're making too much of something and the body needs to not. We actually will give you medication to stop something. I call them the copy keys. The antagonists are the copy keys. They're same shape as the intrinsic drug, but the bond isn't tight or capable of activating the cell. So we'll actually stop the activity from occurring in the cell. They're in competition. So the antagonists are these copy keys that will go into these receptors and either stop an action from occurring. So that's why I say antagonist. Remember, antagonists have effects opposite to agonists. Some drugs can be an agonist to one cell and can be an antagonist to other cells. This is why we need to know the intended actions and side effects of drugs that we're giving. Now, there are some cells that are non-receptor cells. They don't have those receptor sites, so they don't have the lock and key system, but they can affect the cells by either killing the cell directly, cytotoxic, or working on preventing its reproduction or actually changing its reproduction. And a lot of times these are the ones that we're dealing when we're dealing with medications like antibiotics, cancer or chemotherapy drugs, and drugs that decrease blood clotting. They don't have that lock and key system. They actually affect the cell directly. And like I said, by either killing the cell or changing its reproductive, system. So those are some things that those are certain medications that will only work on the cell itself, not those lock and key systems. Now, physiological effects, that is what the patient is going to be feeling or what is observed. Includes intended actions, it includes the side effects, and it includes the adverse reaction. So what the patient is going to be feeling or what is observed the patient doing. Now, intended action, now this is part of also your farm cards. We already talked about it. It is the drug that has to have at least one intended action that we desire. So every drug has to have one intended desired action. Now, side effects, we've talked about this also. It's not an intended action of the drug. All meds have at least one side effect we talked about. Some will go away when the med is stopped. Some will be mild. Some you won't experience anything at all. Okay, for example, we already talked about opioids causing nausea, vomiting, and constipation. Antibiotics are known to cause diarrhea and yeast infections. Antihistamines make people drowsy. Aspirin actually decreases blood clotting, but that is actually a side effect that we actually want to happen for people who are having myocardial infarcts or heart attacks. We want to actually have a decreased blood clotting factor. So that's actually a side effect that is beneficial for people who are having myocardial infarcts. Now, adverse effects or adverse drug reactions, ADRs, these are very harmful effects. These are more severe and can cause damage and health problems. These are the ones that are very toxic, can cause toxicity. These are the ones we're going to see with higher doses. That's why it's important to identify adverse effects so we can either decrease the med dose or stop the medication completely. Sometimes meds need to be continued even with adverse effects because it is the only drug that may give us the desired effect we are looking for. Example, some meds can cause muscle breakdown. Some can cause a serious rash where your skin is actually blistering and sloughing off. And that is called Stevens-Johnson syndrome. And that you can see on page 9 in the book. It is very serious. It can be very deadly. Think about it. Your entire skin is blistering and sloughing off. You're losing a lot of the solution in you. It is very bad. So that is an adverse effect. These are the things that they need to seek medical help immediately. A lot of times with these ones, we will hold the dose and notify the physician if they're occurring. We need to call them ASAP. So those are adverse effects or adverse drug reactions, ADRs. Another thing that we talk about, which is also on your drug card, is black box warnings. Now, not all drugs have black box warnings. So if they don't have it, make sure you mark none on your drug card. But these are severe effects that can be life-threatening. Prescribed to patients meeting strict criteria, and they're on meds. These meds need to be closely monitored. So we have to watch them very closely, and that's very important. Now, when we're talking about allergic response, these are the adverse effects. The drug is given can cause release of histamine and other inflammatory reactions. Allergic responses can be mild, like a skin rash, but they can be severe as anaphylactic reactions, angioedema, which is actually severe facial edema. You can get swelling of the lips, the tongue, swelling in the throat, can't breathe, swollen lips. And you can see a picture of that on page 10, figure 1.6. A lot of these people who are having severe allergic reactions have a sense of doom, and they can also decrease their pulse. So it's very important to monitor these patients very closely. So it's important to ask patients what symptoms they have if they say they are allergic to a drug, because the majority of the time they mistake side effects for allergic reactions. If a patient says they can't take the medications, always ask why. Okay, allergies can occur days, remember weeks, can months, or years after starting a medication. So that's important to look for. That's why we have to teach them what to be looking for. Now, contraindications, these are personal or health-related reasons for not administering a specific drug to a patient or a group of patients. That's contraindications. And that's another thing that you have to address on your drug card. So it's a personal or health-related reason for not administering a specific drug to a group of patients. Now, personal response or idiosyncratic response, these are adverse responses that are not related to the drug. They're very personal. They're not true allergies. They can be related to a patient's genetic. It's how a person reacts to meds. It doesn't mean that someone else is going to have that same reaction. So it's a personal response or it's an idiosyncratic response. Now, pharmacokinetics, that's how our body uses the drugs digested. It's our drug metabolism. It's our body's change the structure of the med in order to prepare it for inactivity and elimination. It's very important to take the medication on a routine basis so the med can continue to act on the body. If the body didn't inactivate or eliminate the drug, it would remain in our body for years, causing toxicity and those adverse reactions we do not want. So drugs must reach a high enough level in the blood or tissues to produce the intended action we want. So we must have enough of it, but not too much where it's going to cause toxicity. So that's important for us to think. Now, another thing we talk about is the minimal effective concentration, or the MEC. This is the lowest level of drug in the blood to produce the intended action. It's a steady state. It keeps things balanced with our medication in our bodies so it can produce the intended action. So that's the, nice steady state that we have. Duration of action is how long the drug remains in the blood at the minimum effective concentration. And of course, the potency, that is the strength of the medication. Increased potency, you need a lower dose. Decreased potency, you need a higher dose. So those are some things the doctor has to consider. And absorption, that is the extrinsic drug that gets absorbed into the bloodstream. Okay, it's absorbed. And last thing we're going to talk about until we get is bioavailability. That is the amount of drug that gets into the bloodstream. All meds that get into the bloodstream give 100% bioavailability. Some meds get absorbed in the bloodstream, which is less than 100% bioavailability. If you give it intravenous or through the IV, that is 100% bioavailability. If you take a pill or do a sub-Q shot or an IM shot, that would be less than 100% bioavailability. It's not getting into the bloodstream all at once. The only one that's going to give you 100% bioavailability is if you give it intravenous. All right, so I'm going to be back with more on this chapter.